Hi, everyone, and thank you for joining us for another discussion. My name is Alyssa Lambrecht, and I'm a third-year medical student at Ohio University Heritage College of Osteopathic Medicine and a Capello Fellow for Doctors for America this year. Today, I'm joined by Dr. Julie Swartz, an emergency medicine physician in Toledo, Ohio, and we're going to talk a little bit about how to avoid burnout when interacting with patients with substance use disorder, what the emergency department looks like, and the care of a patient presenting with any sort of addiction issue coming in, and just having a little bit more of a conversation with this specialist. All right, Dr. Swartz, would you like to introduce yourself?
Sure. Like Alyssa said, I'm Dr. Julie Swartz. I'm an emergency medicine physician at Mercy St. Vincent Medical Center in Toledo, Ohio. I am the clerkship director there and core faculty for the emergency medicine residency program. I completed undergrad at Miami University in Oxford, Ohio, and then went to University of Toledo College of Medicine for medical school, and then I trained at Mercy St. V's for residency. And I've been a practicing emergency physician for 10 years now. So
Awesome. So can you just start by maybe giving, especially like for medical students that may have not had emergency med yet, or for physicians that haven't been around the ED for a while, just what your daily interaction is with a patient presenting with substance use disorder?
sure. We kind of see a couple of different ways that patients come in with substance use disorder. One very common way is that they come in after overdosing. Many times nowadays EMS has Narcan in the field, so it's given to them prior to arriving in the department. So a lot of times they're, no longer overdosing. They're able to speak with us. The emotions of the patient when they come in after being treated is very much varied. Sometimes they're very relieved. Sometimes they're angry. Sometimes they're very upset, and it's kind of their breaking point where they understand that they need to get some help. But it's very varied, so you never know what to expect when you get the call that somebody's being brought in who had just overdosed. And then other times they're, still kind of actively overdosing, and we have to actively provide medical treatment and provide the Narcan, resuscitate them, and then kind of wait for a while for them to wake up to be able to really have a conversation with them.
Mhm. What do you feel like your colleagues and maybe students that you're training, like what are their thoughts and attitudes when these patients come in?
That's varied also. Sometimes there's a lot of us, I think, that have experienced personally substance use disorders in loved ones, and kind of understand more, have an understanding better that this is really a disease and how hard it is for these patients to get help. And I think there's more understanding and compassion there. And then, for others, they don't understand it quite as much, and it's thought to be more of a personal shortcoming or like a moral type, and there can be more kind of hostility toward the patient, like, why are you, I have other sick patients that I need to take care of. Why do I have to stop what I'm doing to take care of you? Obviously, that's not what we want, but I do see that behavior at times.
Mhm. Do you remember going through your training if there was any emphasis on like how to provide the most compassionate care for patients with substance use disorder, and if that's something you've tried to incorporate into your residency program?
I mean, I know in medical school we had classes, but as far as specifically emergency medicine training, I don't remember back when I was a resident if we had didactics specifically on it. We probably did. I just don't remember. But honestly, in emergency medicine, a lot of the learning is done at the bedside in the department. I mean, we definitely had training on that. Especially, I know a couple of attendings who really have more of a focus in this area, that would, pull us aside and kind of explain, like, this is really what our goals are. This is how you should be interacting with a patient that comes in with substance use disorder. So it was a lot of bedside training.
Mhm. How do you talk with like residents about this when maybe, like you mentioned, some of them haven't quite had an experience of this being a family member? Are there any certain resources that you point out, or just any ways that you try to help them understand a little bit more about kind of leaving those biases at the door, recognizing them in their practice?
Sure. In the moment, I just pull them aside and say, you have to really think of this as a disease, because it is. It's very difficult for, we don't know what the patient's past was. We don't know what kind of trauma they may have experienced that got to them to this point. A lot of times that kind of sparks a little understanding in the resident and makes them feel a little more compassion, I think, towards the patient when you really think about what they may have experienced in their past. And then a lot of times I'll point them to resources. Like there's a book that I read a while back called Dreamland that kind of talks about how the drug epidemic in the United States kind of started. And I think that's really eye opening to a lot of people to see how patients really can get to that point and kind of develop a compassion there.
Okay. Have you ever found yourself feeling burnt out, like when another patient of the night maybe comes in with some of these issues and it's like challenging your patients, and just how do you kind of refocus and like kind of reset so that you can provide them with the best care?
Yeah, I think there's two times where it's really difficult to bring up the compassion, especially one, when patients come in sometimes with substance use disorder, when they're actively intoxicated, they can be not the most kind to staff and even violent at times, and sometimes that can be difficult to kind of step back and say, okay, this is the drugs, not the patient, and to treat them with the compassion that they really deserve. And I think it just takes a minute to kind of calm down and think about that. And then the other side is that the patients that frequently come in having overdosed or coming in because of the effects of their substance use, and they're coming in frequently, but they don't want help. And it can be frustrating when you're trying to help them, but they're just not at that point of wanting to accept it. And that can lead to frustration and even burnout at times. But I think it's just understanding, and again, stepping back and understanding, like, this isn't it's not a failing of mine that I can't help this person right now. It's the patient just isn't ready and at that point. And all we can do is kind of provide them with resources for when they are ready, they'll have them.
Mhm. And for anyone who doesn't know, like Toledo is a pretty urban area. So I'm wondering as well for patients where resource, like being able to go to a family practice or being able to get into any sort of rehabilitation center, maybe like an access to care barrier. What types of resources does the ED offer besides like just in the treatment of an overdose? Is there any other things that the emergency department can do to kind of help facilitate care for these patients?
Sure. So St. V's is very lucky that we have social workers in the department inside in the department 24 hours a day, 7 days a week. So because emergency medicine is a little bit different than some fields where we just a lot of times do not have the time to like sit down and have a long conversation with a patient, we're able to have a social worker come in and actually do that. So if we have a patient that we recognize, they're ready for help, or they could benefit from some resources, we're able to call in the social worker and have that conversation with the patient, provide them with all the resources that they need, and it's appropriate for them to get help. So we do have that. We also are able to now provide some Suboxone in like a kind of specific population of patients. So we've also started moving forward in that direction as well.
Mhm. Okay. Well, that's great. Hopefully, I think there is like some movement towards having the ED be a little bit more able to do some of those like long-term management goals, but it also can be hard when you do have a lot of other patients with very emergent needs. And
Right.
but it does sound like, yeah, having that team there is really important, and that can be really helpful, especially on the days where your patients is maybe running a little lower than what you hope, because we're all going to have those days.
Right. And that's the great thing about the emergency department is that we really are a big team. And we have a lot of resources available to us, like social work and, our nursing staff is great and can kind of talk to the patients too. And we kind of really all work together. So it's not just on one person.
Mhm. Have you found that there's any like advocacy ways that emergency medicine physicians have gotten involved with either like the community or like trying to do any more preventative medicine just in different ways, and like what could maybe an emergency medicine doctor do if they wanted to make a bigger impact in their community?
I think there's always like different community programs ongoing. So getting involved in that. I know I've already done talks at local schools So I think that's a really good way to get involved. High school students especially like to hear about emergency medicine because it's kind of the exciting field. So you kind of draw them in that way, and then have a discussion about substance use and ways to get help if needed, and things like that. So I think those are a couple of ways.
Mhm. Okay. Are there any other pieces of advice you have for people interested in learning more about how to like provide compassionate care, but kind of recognizing some of their own shortcomings, and just kind of improving the care, especially in the emergency department for patients coming in?
Yeah, I think honestly, the biggest thing for me is really trying when you have the time to have a conversation with a patient who's open to having a conversation and kind of getting to know who they are as a person. Sometimes it's easy just to label somebody as, you know, an addict when they're a person, they have a story, and really talking to them and getting to know somebody, or even somebody that's not a patient but somebody in your personal life that you may know that has struggled with this in the past, to get to know their story and what led them to start using and having a problem, to really have a story behind it, I think is what really gives people compassion and understanding. um, but then, like I said, I know that there's um, so many different um, books, and like talking to social workers even in our emergency department who kind of have a little bit more knowledge about the resources on the topic, talking with them about what works, what doesn't work, so that we can lead patients in the right direction.
Mhm. Awesome. Yeah, that sounds, I feel like that's something that people need to realize too, is that there are ways to get better at this skill, that recognizing the biases, kind of understanding that maybe sometimes our patients can run short, and just like finding ways that you can get better at treating the patients and understanding where they're coming from, especially if you hadn't had any experiences in that area.
Right.
Okay. Any last thoughts before we head out for today?
No, I think this work that you are doing is great. I think it's going to be a great help to patients and healthcare clinicians. So I thank you for that work.
Well, thanks for coming. I feel like it's always good to just hear from different specialties and how everyone interacts with patients with substance use in different ways. And as we talked about in our last video, just the prevalence of substance use, that every single specialty, we all have to be treating them, and we all have to understand the nuances of care and how to provide compassionate care. So thank you for shedding a little bit of light into emergency medicine. And other than that, I hope everyone has a good day.